Good evening, one and all. Gidesh, I hope I am audible now clearly.
Yes, sir, you are audible.
Yeah. So today I, Krishna Shetty from Torrent Pharma, take this opportunity to introduce before you a renowned consultant gastroenterologist, hepatologist, and interventional endoscopist, Dr. N. Arun and Dr. M. Hariharan from Apollo Hospital, Chennai. Dr. N. Arun is a consultant gastroenterology with an emphasis on therapeutic and interventional endoscopy. He was also assistant professor of medical gastroenterology at RGGGH, that is the Rajiv Gandhi Government General Hospital, Chennai. Sir has presented many abstracts, posters, and cases in various national conferences. Today, we are honored to have him with us as a speaker for our event. We are also honored to have Dr. M. Hariharan. Dr. M. Hariharan is a senior consultant gastroenterologist. He has special interest in GERD, IBD, viral hepatitis, and therapeutic endoscopy and capsule endoscopy. Today, we have him with us as a moderator for our event. They will be speaking on an interesting topic, that is gastroparesis, a silent enemy. Before I hand over the podium to Dr. N. Arun and Dr. Hariharan, I request all the viewers to please utilize the question answer box for any queries that you have during the course of the webinar. So over to you, Dr. N. Arun and Dr. M. Hariharan.
Good evening, everyone. At the outset, I would like to thank the Torrent team, particularly Mr. Inkersal, who has been instrumental in organizing this webinar. Today, the speaker of the day is Dr. Arun. He's a consultant gastroenterologist. He's a colleague of mine in Apollo Hospitals, Chennai, Greens Road. He has a special interest in interventional endoscopy. He currently works with me, as well as he works as assistant professor in the government medical college here in Chennai. He will be speaking on a very interesting topic, which is gastroparesis silent enemy. I do understand that it is, as he has mentioned in his topic, that it is quite a silent killer. Very, very important issue that many people fail to recognize, that the patient has got a gastroparesis. I would probably hand over the mic straight away to Dr. Arun to start the proceedings, and we will take the question and answers at the end of his talk. Over to Arun. Thank you.
Thank you, sir. Thank you, Professor Dr. Hariharan, sir, to be here, and it was a great mentor to me. Senior most consultant who spent valuable time even in a busy schedule, sir. It's really a great pleasure for me to have you in this podium and for this area for discussion, sir. So I'll be sharing my slides with you all. Whether my slides are visible, sir? Whether my slides are visible?
Yes.
Yes, sir. Yes, sir.
Yes. At the outset, I would like to thank Torrent team who gave me an opportunity to share some knowledge and perspectives, what is happening right now in the field of gastroenterology, to discuss about the most common scenario that most of the practitioners will be having difficulty in recognizing, difficulty in tackling this presentation. Even for the gastroenterologist, is a huge hurdle for us to tackle this kind of presentation. It's nothing but a gastroparesis, a silent enemy. If you want to discuss about this topic, it's one of the complex entity for you to understand, but I would like to make this topic a very simple scenario you should remember before you're going to wind up this session. And what do you mean by this gastroparesis? Say anything which is going to produce a heart, which is going to produce your paralysis in your stomach, which means it's going to be a partial paralysis. So what is going to happen? There is no evidence of any mechanical, not any evidence of mechanical obstruction. What is to empty your gastric content? up with varied presentations. The most common presentation will be a nausea. See, nausea, it can be originating either from your epigastric area, it can originate either from your periumbilical or your belly button area, it can originate either from your appendix, or it can originate either from your small bowel. There are so many areas for you to have this kind of nausea, which is going to predispose to this kind of presentation. So I would like to point, based upon, even if you're going to have varied events, for example, in small bowel, if you're going to land up with small intestinal bacterial growth, or in case of any peptic ulcer, in case, all this presentation will always mimic your gastroparesis. There are so much a differential diagnosis if you want to recognize this presentation at an earlier point of time. The most common event will be your postprandial fullness, your early satiety, your nausea, your vomiting, your bloatedness of abdomen will be a common predisposing factor. Because of this, even now, more hospital admissions is being happening nowadays, and it's very difficult to manage even for the best of gastroenterological center to tackle this presentation effectively. So how to diagnose this gastroparesis is mainly by the symptom of your gastric, without any evidence of gastric outlet obstruction or any evidence of ulceration, but there might be a delay in your gastric emptying. What is going to happen? Either it could be accelerated, always you should remember differential diagnosis. It could be because of either accelerated gastric emptying also, and functional dyspepsia will always mimic your gastroparesis like symptom. To prove that, we need to go for a baseline investigation. There are so many investigations for you to identify prior to initiate the patient with prokinetic support. You need to go for either gastric stimulation therapy, all those modalities to be analyzed properly if you want to manage a patient with gastroparesis. Basic definition about this gastroparesis being broadly categorized into three various areas. One is by definite gastroparesis, and another one is by probable, and another one is by possible. What is the definite gastroparesis? You need to show a delay in your gastric emptying mainly by your standard scintigraphy, along with your various symptoms that what I've been explained to you before, and with which pain along with evidence of your epigastric pain, which is going to last for more than 3 months. So you need to document by your investigation profile along with your clinical presentation, which is going to be there for more than a period of 3 months. That shows evidence of definite gastroparesis is there. But what do you mean by probable gastroparesis? It's symptoms as above plus food retention on endoscopy if you're going to identify, or in upper GI study, but scintigraphy and other indications and other higher investigations, if you're not going to do, there might be evidence of suspicion of gastroparesis that shows probable gastroparesis. But possible gastroparesis is only by scintigraphy we are going to recognize, or without any major evidence of GI symptoms, or typical symptoms only if it is going to be there, that shows evidence of possible gastroparesis is also there. So why we are checking, why you have chosen this topic, one most complex entity for today's discussion is the burden of gastroparesis. If you're going to look into that, in female population is going to be more common. Now, even we are looking for the various risk factors like diabetes, thyroid, obesity, so many other complex risk factors are there, which is going to associate with gastroparesis, but the greater incidence in women with non-diabetic gastroparesis is slowly going high, along with it has been increased almost around 138% of hospitalizations from 1998 to 1995 to 2004 being recorded. So as the age progresses, the burden of gastroparesis is still going high, and male gender, there is high possibility for you to have worsening mortality, and non-diabetic gastroparesis, there is evidence of a increased survival being proven. So at the outset, before talking about this gastroparesis, we should know the basic gastric function, how the gastric function is going to happen, how the gastric emptying is going to be. See, you're going to look into that. The main thing, the fundus, the corpus, the body, and antrum, what you're going to look into that. So in the main area, the stomach is going to act like a reservoir. Once your stomach is going to accommodate your food, what is going to happen? Followed by, it needs to propel the content into the antrum. So it be establishing a process of formation of chyle. So what is that? Nothing but a trituration process. Trituration process is going to start in. Once the mixing of your food with your gastric secretions, followed by, if it is going to get empty into your duodenum, all this process is going to happen in a normal way, which will predispose to a normal gastric emptying. In case if there is any hurdle in between, it shows evidence that the gastroparesis is going to set in. So what is the major 3 layers which is nothing but, as we all know, the basic physiology. If you're going to look into the stomach, it comprises of your outer longitudinal, your middle circular, and inner oblique layer. So why I would like to state that the circular layer, which is predominantly being located in the antrum, which is showing a maximum thickness, there where the contraction will be the greatest, the food propulsion activity will be the greatest, which will be emptying into your pylorus, followed by the contents is going to rush out into the duodenum. That's why the circular layer is going to take a major part, along with the longitudinal layer. If you're going to look, it's predominantly in your distal two-third, but the oblique layer will be in the proximal of your stomach. So the mainly by your neural innervations, what is going to happen? Your myotic plexus is mainly coordinating your sympathetic as well as your parasympathetic activity. If it is going to be in a strong way, which shows your emptying has to happen. But once of emptying, if it is going to any neurogastroenterological association, if it is going to happen, if it is going to have any tachygastria or bradygastria, that shows evidence of your delayed gastric emptying. That is the area of gastroparesis to set in. So what is this normal gastric emptying? It's mainly based upon two major mechanics. You should remember that the reservoir, the stomach reservoir, what is going to add? It's mainly by two contractions. One is by a tonic contraction, which is going to initiate in your fundus, and next to that, a peristaltic way, a phasic contraction, which is going to happen in your distal body and antrum. So these two contractions, which is going to aid in your digestion of food digestion process, followed by it is going to empty the chyle mechanics. The food will be going back, the retropulsive flow, the retrograde flow, the forward flow, all this things is going to happen, followed by there might be evidence of your transpyloric sphincter mechanic action that shows this emptying mechanism which is going to happen in a normal way. So in the region of your body of the stomach, the peristaltic wave only produces a small circular constriction mechanism which is going to happen. So always you should remember both the peristaltic waves and your tonic contractions of the reservoir are stimulated mainly by your cholinergic neurons, which is going to innervate, which modulates your vagal control. So once the peristalsis is going to set in, you should remember that pacemaker potential. So you see this picture, the most important thing, the pacemaker region of your stomach, it's nothing but your interstitial cells of Kaggle. Where is it going to locate? It's mainly locating in between the fundus and the corpus of your body. Once the pacemaker potential, if it is going to get activated, the 3 CPM, means 3 cycles per minute slow waves, it's going to get initiated, followed by your food contents. It's going to empty into your corpus and then into antrum and then into pylorus and then into duodenum. This is how your peristaltic mechanism, a peristaltic contraction, is going to set in. The action potential is going to take on from that point of area. So the antral pump is the main area. That's the area of the titillation, the chyle formation, all those things is going to happen. The antral pump is the main thing which will be acting as a sleeve, as a sieve. So what is going to happen? The liquid content is going to empty more rapidly rather than your solid content, but it will be because of the chyle formation, the chyle mechanism. So what is going to happen? The lumen of the antrum, it is not going to get occluded by the peristaltic wave. And some amount of chyme, if it is going to get flow in a retrograde manner, that shows evidence of your proximal antrum if it is going to get relaxed. Once all the process, if it is going to take on to your proper mechanics, your proximal antrum. See, if you're going to look into this phase, there are 3 phases of contraction. One is by a phase of propulsion, and second to that, your phase of emptying, and third is a phase of retropulsion. So which is going to happen mainly in your proximal antrum and middle antrum and your terminal antrum. What is going to happen once the proximal antrum is going to take on, the chyme is going to propel into your terminal antrum, followed by a duodenal contraction is going to start initiated. Once the phase of emptying, it is going to get activated. There might be a transpyloric. See, there might be evidence of transpyloric and retrograde flow, along with evidence of your duodenal relaxation is going to set in. But once the phase of retropulsion has been taken over, the contraction of the terminal antrum, which will predispose to a jet back flow with grinding by duodenal contraction. All these mechanisms is going to establish your digestion process to take on in a normal way. This is what the normal gastric emptying is going to happen. If you're going to look into this phase, once you're taking the viscous content, the time of emptying will be slightly delayed. But once you're going to take your liquid food, the rapid emptying of your food without taking much of your lag phase, it's going to happen mainly by your normal gastric emptying, which is going to happen. So what are the various factors physiologically and pathologically, physiological factors which can affect your gastric emptying? Mainly, what are the various factors which can increase is mainly by your stomach distension, and next to that, your liquid content. Once the liquid content is high, there might be evidence of your rapid gastric emptying and smaller particles of food size, mainly by your parasympathetic stimulation. But what is going to happen once the patient is going to land up with delayed gastric emptying, mainly by once the duodenum is going to start distending, as once after the trituration, all the process, crime mechanics, all this process getting completed, the duodenum getting distended, followed by the chyme, which contains high level of hydrogen, fat, and protein, the diet what you're going to take, along with your various secretory products like secretin, cholecystokinin, and various natural physiological process like your pain, anxiety, stress, and your sympathetic activation will always delays your gastric emptying. So if you're going to look into the starting from your dyspeptic presentation, starting from your functional event, all those major mechanics is going to take into mainly by your fundus, which shows your relaxed, once it's going to get accommodated with large amount of meal, that shows evidence of which is the trituration process line antrum, which is going to take on, along with start grinding your food, formation of chyme, it's going to get start off, and phasic contractions and feedback mechanism is going to get established in your small intestinal process. This is how the normal mechanism. What is going to happen once the patient is going for gastroparesis? If you're going to look into this diagram, the normal mechanics by your fundic relaxation and emptying of your contents, your carpal filling, followed by an antropyloric contraction, your duodenal resistance. So many mechanics are there for your normal gastric emptying. So once a gastroparesis, if it is going to happen, what is going to happen? There might not be your fundic relaxation. The fundus is not going to get relaxed properly, because suppose in case if you're going to land up with diabetes, your neurogastromotility problem is going to get set in, followed by your vagal afferent nerve pathway. If it is going to get disrupted, there might be evidence of your action potential delay, which may predispose to your gastric dysarrhythmias, either by tachygastria or by a bradygastria, which is going to take on when you're going to record your pacing value, followed by there might be evidence of your delayed gastric emptying, antral hypomotility, and the gastroparesis is going to take on, along with evidence of pylorospasm. So this is what the basic pathophysiology, how the various clinical presentation is going to get happen. Once the patient neuronal disruption is going to be there, the NOS, the nitric oxide synthesis, is going to get come down in your neurons, followed by in your fundus, there might be evidence of decreased accommodation, which will predispose to bloatiness and early satiety-like presentation. And once it's going to happen, the gastric dysarrhythmia, if it is going to take on, that's an area where you're going to have a nausea-like presentation. And once your electromechanical activity, if it is going to get impaired, the nausea and vomiting, it's going to get worsened. And all these mechanics is going to take on by your dorsal root ganglia, the caudate, the thalamus, all the putamen, all this nucleus, which is going to get involved in that area, which will be predisposing to this gastroparesis mechanics to get set in. That is why the neurogastroenterology, which is being discussing in this area, is one of the complex phenomena to understand. The basic pathophysiology, it's a huge area, and you should remember some certain concepts before winding up this session. So the sensory neuropathy, in case if you're going to have any problem based on that, there might be evidence of your pain, which is going to predispose in your gastroparesis. This is how your clinical presentation for your gastroparesis, followed by the pathophysiological events, is going to take on in this mechanic. So there are multiple mechanisms which is going to play the change in gastric emptying, because usually being compared to your change of symptoms. So how to recognize? How will you recognize a patient? This is the second area after discussing about the pathophysiology of gastroparesis. How are you going to recognize, identify the cause for gastroparesis? Always you should remember, any patient, you should not jump into the conclusions mainly because of gastroparesis who is going to land up. We need to have a detailed clinical history, detailed clinical examination, your endoscopic assessment, sometimes your neurogastroenterology, motility studies, all those things to be done before labeling as a gastroparetic disorder. So once the patient, if you have any strong suspicion, you need to look for the basic triggers like diabetes. Always you should remember, it's one of the worst event, even in type 1 and type 2, that I'll be taking on in my upcoming slides, along with your thyroid dysfunction, any neurological disorders, in case if you are going to land up with any surgical event or any autoimmune pathology, all these parameters to be analyzed. So head to foot examination to identify the cause for gastroparesis, what is the event which is going to set, and you need to do it properly. Next to that, in case some patient may land up, I have seen few days before also a patient who presented to us with evidence, even post-COVID scenario that shows some evidence of gastroparesis being taken on. All this post-viral event, we need to look into the scenario before taking on the discussion. And make sure your glycemic control, that is the most important area for me to talk on. If you are going to hypoglycemia, that might be having a rapid gastric emptying. Once a patient is going to have hyperglycemia, if it is going, blood sugar, if it is going to be more than 200, it shows evidence of delayed gastric emptying. So you need to target your glycemic control by optimization of your insulin therapy. That's the most important area in managing a patient with a diabetic gastroparesis. Next to that, some medications, in case if you're going to use like GLP analogs, so you need to be very conscious diabetes. You need to make sure this kind of drugs that might be having evidence for you to land up with gastroparesis. And look for the very differential diagnosis, which can always, gastroparesis can aggravate your ulcer disease, gastroparesis can aggravate your gastroesophageal reflux, and always you need to look for the patient who's going to present with refractory to acid suppressive therapy is there or not, for this kind of patients to take on the discussion. And to talk about the basic etiological factors, most of the time we couldn't able to identify what is the etiological factor for gastroparesis. In medicine, that's the most common scenario. If you couldn't able to find a cause, it will be idiopathic. Always we need to label, we need to take that as a strong pointer in the discussion. And next to that, your diabetes will be in a second position, followed by your any post-surgery. It could be because of your fundoplication or vagotomy, so many other surgical procedures or multiple medications, for example, opioid analogs, opioid derivatives, and next to that, your various neurological disorders, which will be predisposed into dysautonomia, for Parkinson's, amyloids, all this presentation, any post-viral, your rheumatological association, for example, scleroderma, and your, in case if the patient is going to have a chronic kidney or renal insufficiency, that might be evidence of gastroparesis also in the background of a chronic profile, disease profile. So to talk on this idiopathic gastroparesis, in which we couldn't able to establish the cause, most of the time will be occupying a predominantly younger age of population, and women is most commonly be involved in this kind of presentation. You need to look for whether the patient is going to land up with functional dyspepsia as per the Rome categorization, or it could be because of idiopathic gastroparesis. In functional dyspepsia, abdominal pain, discomforts predominantly will be there, and early satiety, bloating, bloatedness, and nausea, vomiting will be predominantly in gastroparesis. And we need to look for, before starting the therapy, as per the clinical assessment, we need to look for the basic workup. How are you going to diagnose this gastroparesis when compared to your functional dyspepsia? So this is the basic outline study about your diabetic gastroparesis. What is going to happen? Your glucose and gastric emptying, how is it going to impact? So once the patient is having increased rate of gastric emptying, if the patient is going to have a postprandial glycemia, if the patient is going to land up with hyperglycemia, it will predispose to your reduction in your gastric emptying. That might be your gastroparesis is going to happen. Once a patient is going to be having evidence of hypoglycemia, that might be having evidence of increase in your gastric emptying. So most of your contents, glucose entry is going to augment by your small intestinal, the gut neurohormones, which is going to be there. For example, your cholecystine, cholecystokinin, along with your protein PYY and GLP analogs, along with your amylin, all those things is going to get involved, followed by the stimulation of your beta cell, which will be predisposing to insulin release, and alpha cell, which will also decrease in your glucagon, followed by this mechanics of glucose entry into small intestine. Thereby, it is going to augment your gastric emptying, which is going to happen or not. That's the area for us to discuss right now. And once the patient is going to land up with this kind of delayed or accelerated gastric emptying, what is going to happen if you're going to have diabetes? Either it could be because of your delayed gastric emptying, or you may have a normal emptying, or you may have a rapid gastric emptying. See, if you're going to look into this scenario, what have been taken from a recent paper, so if the patient is going to land up with a rapid gastric emptying among the prevalence without upper abdomen, that shows evidence of 20 to 20% of the population, but with in the background of predominance of upper abdomen symptom, that shows evidence of 20 to 30%, and accentuation of early postprandial hyperglycemic peak is going to be there. And in delayed diabetic gastroparesis, there might be evidence of your delay early postprandial hyperglycemic peak is going to be there. So this paper is very important to document your hyperglycemia events, what is going to happen in your gastroparesis. Briefly about diabetic gastroparesis, the term coined by Boyes et al. In 1925, and gastroparesis diabeticorum is one important area to take on the discussion. If you're going to look into that, the main area is type 1 diabetes of long-standing duration will be around 20 to 50% of the population in diabetic area rather than in type 2 diabetes. So the mean age of approximate will be 34 years, and the delayed gastric emptying will be universal. More than 20 to 27 to 60% of the population with type 1 will be having delayed gastric emptying, and in type 2 will be around 30% of the population may be having this kind of presentation. So what is going to happen? You need to look for other coexisting picture of your diabetic gastroparesis, your retinopathy, your peripheral neuropathy, your cardiovascular events, and your high level of your mean HbA1c, your nutrition status, your socioeconomic status. All those things is going to have an impact among 5% among all the people with diabetic type 1, and in 1% among the people with diabetic type 2. This kind of presentation, always we need to look into that, and your poor quality of life, like your worsening of bad habits, and all those things is going to predispose for this event to set in. So what is going to happen for your gastric emptying if it is going to get delayed in diabetes mellitus? What the main area, if you are going to look into that, what is the pathophysiology which is going to happen in your diabetic gastroparesis? They see the innovation, the denervation process is going to get delayed, get disrupted. The extrinsic denervation, which is going to happen, followed by your delayed gastric emptying, is going to get taken over. And next to that, your nitric oxide is strong potential vasodilator, which is going to happen. What is going to the impaired inhibition of your smooth muscle, which will predispose to your gastric accommodation if it is going to come down, and possibility of accelerated gastric emptying of liquids is going to take on. And next to that, your uncoordinated antral contractility is going to happen, followed by your pylorus spasm. That shows the evidence of gastroparesis is going to take on in this area. And you should remember that pacemaker potential, which is going to happen in the interstitial cells of Kaggle, it is going to get disrupted. The decreased smooth muscle contractility is going to get happen because of loss of your ICC, and dysarrhythmias is going to take on in your gastric motility. And next to that, there might be evidence of your altered immune function once a patient is going to land up with diabetic gastroparesis. That shows the evidence of your type 2 macrophages, which is going to come down in your, might contribute to your gastroparesis, followed through a loss of your cytoprotective factors, which is going to damage your ICC, that what I've been discussed with you, along with it's going to impact your smooth muscle contractility. That's why you need to play in this various area, your diabetic gastroparesis is going to take on based upon the various pathophysiological mechanism which is going to be augmented. So to discuss briefly about the post-viral event, any post-viral scenario can predispose to gastroparesis for a short lasting time. It could be along with nausea, vomiting, diarrhea, cramps. All those presentation can be a preceding viral prodrome can be there. And always you should remember, if the patient is going to land up without evidence of autonomic neuropathy, the prognosis will be better. But once a patient is going to land up with evidence of autonomic neuropathy, there might be evidence of poor prognosis. The common etiological trigger will be your CMV, your EBV, your varicella, and COVID scenarios. Now, even post-viral gastroparesis, there are multiple case reports being there. If you're going to look into that scenario, it's a separate area for discussion. It's not my interest to take on, but you should remember, any viral events, there is high possibility followed by that event for you to land up with gastroparesis. Post-surgical, because of your vagal disruption, the most common pathology for you to land up with gastroparesis. What is going to happen? For example, fundoplication, Billroth surgery, Billroth 2 gastrectomy, your bariatric procedures, your varices sclerotherapy, your Botox injection. There are so many procedures may predispose to post-surgical gastroparesis, but it usually happens within the period of first 3 months. And for example, your Roux and Y gastrojejunectomy also may predispose to slow emptying from the gastric remnant and delayed transit in the denervated Roux efferent limb. So there is high possibility for you to land up with Roux-Weiss Chase's syndrome also. So post-surgical gastroparesis, we should not forget that. So how are you going to recognize the vagus is not going to be active? Vagal injury, how are you going to be documented? You need to do a sham feeding assessment. So you need to look for your pancreatic polypeptide in response to your sham feed. After that, you need to look for your vagal stimulation. The pancreatic polypeptide, it should go at least around 25 picograms per ml in the first 20 minutes, followed by it has to return to its baseline. If there is any evidence of vagal injury, that might not be having any response for this stimulation to happen. And iatrogenic gastroparesis is mainly because of your vagal trauma. And next to that, there are multiple drugs are there. A huge list of medications can predispose to gastroparesis. The common medication, if you're going to look at the alcohol itself can worsen, and your beta agonists, your calcium blockers, anticholinergics is most commonly used. We need to consider that in your neurological medications, like your Parkinsonism medication, like levodopa, so many medications are there to consider, and some rare neurological causes like Parkinsonism, amyloidosis, paraneoplastic disorders, your scleroderma can all predispose to gastroparesis. So what is the basic epidemiology? If you're going more than, or if you're for every 1 lakh person, around 2.5% of the population, there is high incidence, and in men, in women, there will be around 10% of the population is going to get involved. The prevalence rate is also higher for women when compared to men, and the delayed gastric emptying is universal. Almost 20 to 40% of the patients in functional dyspepsia, and 26 to 70% of the population with diabetes mellitus. There is high possibility for you to land up with gastroparesis. And the risk factors will be your female sex, your diabetes, your obesity, and no significant association has been proven with your cigarette or alcohol. And female is always more because of your defect in your neuronal oxide, nitric oxide synthase pathway. That shows evidence of dimerization between females and males, which has been proposed to be a reason. It's a hypothesis, hypothetical concept being derived for that. Also because of your progesterone effect in your gastric emptying, also by your autoimmune pathology, more common in females. That shows, that's why the reason mechanism for your various concepts for you to identify for female preponderance in case of gastroparesis. How to diagnose is one very complex scenario. It's very difficult because to whom we need to subject this investigation, where the investigation is being done, how far it is being clinically utilized in our center in India. These are all the areas still unanswerable. So many questions are there to identify. But clinical representation, clinical markers that what have been discussed with you, nausea, postprandial distress, bloatiness, all those pointers to be taken. And then we need to go for a huge battery of tests there. With the basic mechanism, you need to look for your gastric emptying scintigraphy. How much of your food contents is written in your stomach after 4 hours of your food intake? It shows evidence of scintigraphy, whether your gastric emptying is intact or not. And next to that, we need to go for your GEBT, nothing but a gastric elimination breath test. All those things can be done for you to identify this gastric emptying process is being there active or not. So the main mechanism, you need to titrate your glucose before establishing that. Make sure hyperglycemia, you need to control by optimizing insulin. The blood sugar should not be going more than 200 to 250 at that point of juncture. And you need to, if you want to discriminate basic medications, in case if you're going to have any other medication which may halt your gastric emptying, need to stop the medications at least 48 to 72 hours prior to diagnosing this procedure. And hyperglycemia, always you should remember that should shows evidence of your delayedness in your gastric emptying. So always we need to titrate, we need to maintain our sugars. There should be a relative euglycemic range. That's a target potential to be achieved if you want to manage, if you want to establish the diagnostic possibility for you to identify the cause for gastroparesis. There are huge list of tests, mainly by your scintigraphy, your isotope breath test, and your wireless capsule motility. What you're going to look into that. So if you're going to see the main gastric scintigraphy is widely available, that shows evidence of radiation exposure because of the one strong disadvantage for that. And wireless motility, no much of radiation, but less validated when compared to scintigraphy. Your radio label carbon breath test based upon your oxalic acid measurement or spirulina, all those things, it's not much being standardized in India. So these are all the various modalities for you can diagnose. So what you're going to do, your gastric emptying scintigraphy. If you're going to take a meal within a 4 hours period, you need to identify, that's the most important thing, the upper limit of your gastric retention at 2 hours and 4 hours followed by the consumption of your food, you need to see. And if it is going to be more than 60% at 2 hours, and it should be around 10% at 4 hours to be documented. And over the 4 hour period, the most of the gastric emptying has to be analyzed properly. And the various diet patterns based upon your Western style or based upon your Asian style patterns, you can use a rice-based meals which composed of your steamed rice, your egg along with your water, which contains equal proportion of 50%, more than 50% of your carbohydrate with reasonable fat and protein to be taken for your gastric emptying, which is going to happen properly or not. So the main thing, if you want to look into that, we need to calculate the gastric emptying off life. The T off has to be analyzed is if it's also acceptable if imaging has been performed for 4 hours or at least of your 50% of the emptying time. So we need to document by 1 hour, 2 hours, and 4 hours, the serial measurement of your scintigraphy has to be done if you want to look into this, the gastric emptying is happening properly or not. See, this is how the useful presentation, what I would like to show it. See, in case of diabetes, there might be evidence of accelerated, the gastric emptying will be too much accelerated, and the diabetic gastroparesis, the emptying rate is going to come down, and normal gastric emptying, it's being around 91%, which is going to happen, which is going to be releasing slowly in over a period of time. So once the patient is going to land up with diabetic gastroparesis, the first and foremost investigation, we need to go for your scintigraphy, whether it is there or not, how to identify based upon the potential, what have been discussed. And next to that, the other new addendum therapy like your isotope breath test, nothing but your breath testing technique. What you're going to do, preparation. There might not be evidence of any radiation exposure, but once you're going to consume your 13C, so we need to reflect your breath. Serial time interval, we need to see how far your carbon is going to get eliminated in your breath. That's how we need to see your stable isotope breath test, whether it is going to act on your gastric emptying, it is there or not. So simple outline of this procedure: overnight fast, you need to collect pre-meal blood sample and prepare your GEBT, that's gastric emptying of your breath test meal. So based upon your 13 carbon isotope preparation, you need to consume the meal. And once you're going to finish up your meal, you need to set your timer at 0 and slowly every consecutive 45 minutes of duration, collect the breath samples and need to analyze and you need to document whether there's, emptying, whether the breath test elimination is being proper or not. So based upon that, you need to document your gastroparesis. And next to that, what you're going to do is wireless motor capsule. What is you're going to place a wireless capsule inside your antral cavity? What is going to happen? We need to measure your pH. So once the pH of stomach, it should be acidic. But once if it is going to be into your duodenal contents, there might be evidence of alkaline pH is going to take on. So how far the gastric residence, how far the acidic pH and followed by how far the alkaline pH medium, if it is going to get retained, for that shows evidence of your emptying rate, your gastric emptying has been active or not. And that shows high correlation of around 85% with your, more than 90% of the gastric emptying by a scintigraphy process. So we need to look into that. A 5-hour gastric residence time by your wireless motility capsule was best to differentiate the subjects with delayed or normal gastric emptying based upon your scintigraphy, which is being conducted simultaneously with sensitivity is almost around 80 to 85%. So this is how you need to look by your wireless capsule. You need to see your pH and slow from gastric to a small bowel transit. What is going to happen, followed by you need to record your pH temperature based upon the wireless motility capsule assessment. And anteroduodenal manometry, you need to assess the pylospasm. How far the pylospasm? There are so many modalities. You need to look for that. You need to see whether the contraction, which is going to happen at 3 cycles per minute, which is going to be there or not. And it shows evidence of gastric tachyarrhythmia or dysarrhythmia, all those potential which is going to be there or not. And pylospasm, which is going to be active or not based upon your Marin et al. There are so many, but anteroduodenal manometry, there are no much of documentation now in many centers, but we can try. That's also one more modality for you to aid your gastroparesis. And this is what the newer presentation being taken from a recent paper, your flip process, your Endoflip, nothing but your functional lumen imaging probe. So you need to do this flip mechanism and you need to assess your antral diameter, antral, emptying time, antral potency, all those things you can analyze by your gastric emptying, what is going to happen based upon your flip, which is going to be involved. And next to that, there are multiple other modalities like your ECG, electrogastrography, that's a common thing. And next to that, your various accommodation studies, your satiety testing, your barostat testing, and newer modalities like your imaging modalities like SPECT analysis, the single photon emission, computed tomography, and your gastric MRI can all be tried. You need to assess your accommodation. You need to assess your fundic relaxation and how far the MRI is going to get useful. There are so much of sensitivity being there in you for you to identify the gastroparesis is being there or not. But how frequently we need to apply to the patients, the cause, the financial constraints in India, all those things has to be taken care of promptly if you want to manage that. And autonomic testing sometimes and deep tissue biopsies can also be considered. Differential diagnosis is a huge list for this gastroparesis. It's mainly, if you want to remember, one thing I would like to say, remember cyclic vomiting syndrome, functional dyspepsia, your GERD, and cyclic vomiting, you should remember that it's mainly a stereotypical pattern of presentation, and there might be evidence of accelerated even high emetic period, followed by the patient will be stable, and this without any evidence of your neurological or gastric or any other coexisting picture. There is a huge potential area for us to discuss about the cyclic vomiting. And if you want to look for your H. pylori based, your ulcer related disease, and rumination. Rumination is also one more important entity for us to remember, that you are going to take your food followed by you're going to ruminate, like what is going to happen for your cow. So how are you going to ruminate? That shows your delayedness of your gastric emptying might be there. And in case if you're going to land up with any psychological disorders, for example, bulimia nervosa or anorexia nervosa, these are the areas where maybe having a delay impairment of a gastric emptying, and that shows evidence of weight loss is going to happen. All this picture, you need to analyze so much of differential diagnosis. And remember that medial arcuate ligament syndrome, recently also some paper being reported based upon your Dunbar syndrome. All this picture can remember, it shows evidence of your gastroparesis is being to take on with the discussion. And we need to exclude the possible differential diagnosis as I discussed with you, analyze the history, do proper documentation, and look for evidence of closely associated differential pointers that what have been discussed, like your rumination, your cyclic vomiting, your anorexia nervosa, your bulimia pathology, all those things to be analyzed properly. And you need to look for your various conflicts interest of research, which is going to get happen. And based upon that, you need to document your clinical findings. You need to manage your gastroparesis effectively. So to start on my discussion about the basic management in gastroenterology, the first thing for any management, assessing the event, eliminate the trigger, control the precipitating factor. For example, if you're thyroid, treat your thyroid problems. If you're diabetic, treat your diabetic problems. Control your hypoglycemia. And next to that, the main thing in gastroenterology to look for evidence of gastroparesis is your nutrition support, improve your nutrition and fluid and electrolyte support, along with your optimization of insulin in diabetic management. All these things to be analyzed, and always the enteral oral intake is preferred rather than going for your parenteral or other varieties of nutrition. And next to that, oral intake is a preferred modality for your hydration process, which is going to get happen. And either if you want to, in case if your oral intake, if it is not going to be adequate, you need to go for your enteral alimentation by either a gastrostomy or your jejunostomy. Predominantly by a jejunostomy feeding tube can be considered, but usual indications in case if you're going to have a significant weight loss, if you're going to have a refractory gastroparesis, if you're going to land up with repeated evidence of hospitalization, and your enteral alimentation for post-pyloric feeding predominant modality, because gastric delivery may be associated with your poor deliverance of your erratic nutrition support may be there. So always you need to cross the pylorus. Post-pyloric feeding mechanism is very safe for you to initiate this enteral nutrition. And basic classification for this gastroparesis, you should remember that. What is this mild? What is this compensated? What is the process for this gastric failure to happen? So grade 1, which means you can easily control your symptoms by diet and lifestyle modifications. What is this grade 2? You may need to go for a nutrition support. Sometimes you may have your partial control of your symptoms and you may go for hospital admissions also. What is this grade 3? Gastric failure mechanics is going to take on, along with which is not going to respond to your medical line of management. You may need frequent emergency room visit, which may require frequent hospitalization. That's how the grade 3 process is going to take on for severe gastroparesis. The basic algorithm, clinical history, your basic lab tests, look for the precipitating events, do the basic endoscopy, sometimes your contrast imaging along with your scintigraphy and breath tests. So analyze your various markers, and based upon that, you need to diagnose your hypomotility, your gastroparesis is there or not. Huge list of drugs is there to treat, but the baseline diet and lifestyle modifications are most important. The drug list will be your prokinetics based upon your metoclopramide is the most important drug. You remember that. Next to that, domperidone and your various antiemetics like ondansetron. Next, one more thing, your motilin agonist like erythromycin. We should not forget in the management of gastroparesis. And always GI symptoms will always go with a neurological event. So without evidence of antidepressants, without usage of anti-anxiety, most of the gastroparesis is very difficult to tackle. And you need to go for tricyclic antidepressants sometimes. And there are newer molecules like ghrelin agonists, like relamorelin, so many other newer molecules being tried. And apart from that, sometimes you may go for your surgical modality, and sometimes you may need to go for your endoscopic or electrical stimulation therapies and various endoscopic modality of therapies, like going for botulinum toxin and passage of your gastrostomy tubes, and all those things can be tried. This is how, once you're going to suspect a patient with gastroparesis, basic clinical assessment, your diet should not be having high fat diet. It should be a low fat. You need to look for eliminating your hypergenic focuses, the glycemic control. Low fat diet is predominant modality, and your prokinetics, where you're going to use is most important, and look for the side effects of your prokinetics, what you're going to target in that, and your nutrition support either by parenteral or enteral nutrition, and next to that, your non-pharmacological treatment followed by your endoscopic approach or surgical line of modality for you to treat that. So the basic diet should be, we need to maintain a diet of almost around, we need to give a calorie of around 25 kilocalories of into current body weight. That's the calorie we need to target. So we need to go for small, low fat, low fiber meals, which is almost equivalent to 4 to 5 times a day. And you need to increase your liquid content component of your meal, and low fiber residue is the most important thing. And frequent small dieting is the most important area for you to analyze. And 4 to 5 times a meal, you need to divide enteral nutrition, that what I've been discussed. Either you need to go for a nasogastric or a nasojejunal, but nasojejunal is always more recommended to prevent your erratic nutrition support. And next to that, how you're going to set your infusion rates is mainly by 20 ml per hour. You need to target your infusion rate for it to support your nutrition and hydration, at least around 60 ml. And we need to go over a period of 12 to 14 hours a day to maintain your enteral nutrition adequately. This is how we need to target for in case if you're going to hospitalize with evidence of gastroparesis. And tight glycemic control, optimization of insulin, and stepping up and stepping down protocol of your insulin regimen, 0.1 units per kg per hour. How are you going to titrate? That's a separate area for discussion. You should remember that titration of insulin for diabetes is most important for managing a patient with gastroparesis. And this is all the various, decompressive regimens for feeding, either by NG tube or duodenum or gastrostomy, or by pacing a percutaneous endoscopic gastrostomy, a jejunal augmentation, or by jejunostomy or dual gastrostomy, various modalities being there. There are various usefulness being there, but always we need to focus on nasojejunal feeding. That's the most important thing for us to remember before winding up this session. And next to that, strong glycemic control, and make sure that whenever we are going to use GLP analogs, we should be very careful. We may delay your gastric emptying. For example, your pramlintide can also have a delayedness of your gastric emptying. Always you need to facilitate with some other alternative medications rather than going for this diabetic control of medications. The pharmacology, the most important parameter when you're going to use metoclopramide, look for evidence of neurological events like tardive dyskinesia. You need to look for cardiac arrhythmias. You need to see your corrected QTC interval. If it is going to be prolonged, always you should be cautious. So metoclopramide, when you're going to use, you should be very, very careful. And erythromycin for motilin agonist is strongly recommended for evidence of gastroparesis. But in case you need to manage by IV erythromycin or oral erythromycin, you need to give erythromycin formulate, estrolate formulation. So all these regimens can be tried for you to manage a patient with gastroparesis. As I discussed, antiemetics, there might be some role, tricyclic antidepressants, and metoclopramide slowly stepping up from 5 to 10 milligrams, and for it consecutively over up to 220 milligrams TID, and we can go maximum for a period of around 12 weeks of duration. Make sure that the black box warning, tardive dyskinesia, always is a risk factor for you to consider metoclopramide in your management process. And dystonia, a strong adverse event will be reported. So strong titration of your molecule, how are you going to tackle? It's the most important thing. And QT interval, all those parameters, and make sure that you're going to use your drug holidays or dose reductions can be done at frequent intervals if you're going to manage a patient, and look for evidence of coexistent drug interactions, whether it is going to be there. For example, your antihistamines or benzodiazepines, whatever the molecules if you're going to use. And common scenario, common molecule, everyone, every day to day will be using domperidone. And make sure when you're going to use domperidone is going to target your area postrema. So area postrema, once it's going to get involved, you can step up your dose from 10 milligram, 20 to 30 milligrams TDS, whatever you want to give. And it may be, usually will not cross your blood-brain barrier, but there is some evidence of corrected QT interval to get prolonged. Always you need to calculate that. And erythromycin at a dose of around 250 to 500 milligrams can be targeted. And one common adverse event, it will be tachyphylaxis. Once you're going to use this even drug for a longer duration, it may not show an augmented response. That's what is called tachyphylaxis. You should be very cautious. So this is what the basic algorithmic approach. So start from your basic molecule, clinically control, and start with domperidone, look for any metoclopramide, see whether the patient is responding to that, and you need to increase your dose of metoclopramide based upon your clinical response. All those things, if it is going to get persist, you need to look for your re-evaluation of diet pattern, nutritional, and consider a short course of erythromycin in case if you're not going to respond with this basic line of management. And symptomatic treatment for your nausea and vomiting presentation, 5-HT3, ondansetron, granisetron. Nowadays, granisetron patches are available. You can use all those modalities, and cannabinoid analogs can be tried. Transdermal scopolamine, so many modalities are there. Pain management, always you should remember TCA, the SSRI can be tackling in the evidence of depression and diabetes. And amitriptyline. See, amitriptyline, when you're going to use, you should be very cautious because that shows evidence of anticholinergic effects. It may affect your gastric emptying. So not much of. And apart from that, you can use your basic all those things can be drugs which can have an effect, but strong association cannot be established in the management guidelines. And various newer molecules like a neurokinin 1 receptor antagonist, for example, your aprepitant or your trapichant. So what are the molecules if you're going to try? There are various dosage regimens. For example, aprepitant, if you're going to use around 300 to 400 milligrams, the trapichant, it will be around 80 milligrams. There are newer molecules can be tried along with the ghrelin agonist like your relamorelin can be tried. And what is this ghrelin agonist? It stimulates your contractions in your gastric body as well as your antrum. And various 5-HT4 agonists like your prucaloprate, which is being mainly used for your constipation. In this setting also, we can try for evidence of your 5-HT4 receptor agonist, which is going to accelerate your gastric emptying. There are some papers to show that prucaloprate also can be tried in the management, but how far we are going to use in diabetic gastroparesis or gastroparesis of idiopathic origin. So it's still a questionable issue if you're going to manage with this kind of molecule. And interventional therapy, mainly you need to target your pylorus. So pyloric directed therapy. So you can go for Botox injection, you can go for various sites of various quadrants injection you can do. And next to that, you can go for your stenting, and you can go for a surgical procedure. And nowadays the recent innovation, what is called as a GPOM, nothing but gastric peroral endoscopic myotomy, in which you need to create a some tunnel into your antral orifice, followed by you need to inject a dye, and you need to cut the tunnel, followed by you need to using a triangle. And so many modalities are there. And Botox injection, if you're going to inject 100 milligrams to 200 milligrams, we can try. But the problem is the success rate of Botox, the symptomatic improvement in various papers has not been proven. So intraluminal, intrapyloric Botox injection can be tried, but in various papers, it not showed a strong potential response for your pylorus spasm. So the treatment of Botox is still a questionable issue in managing a patient with gastroparesis. And transpyloric stent placement based upon various papers what they've been tried, but the problem is the evidence of stent migration is there. So you need to be very cautious to whom it is indicated. That's how we need to decide about that. And GPOM is one complex procedure can be tried, but the success rate is nowadays even in India is slightly going high. But the various papers, the GPOM just shows evidence of your gastroparesis being improved, followed by your this procedure. So what are you going to do with this GPOM? If you're going to see in this picture, the mucosal incision is going to made into your antropyloric region, and followed by you need to create a tunnel, a submucosal dissection. You need to create a tunnel, and you need to use your triangular knife to cut on the mucosa. And endoscopic, and mainly we need to establish a pyloric arch, and you need to form a myotomy, which is going to get created, and you need to use the mucosal suture clips finally once the process of everything is going to get completed. And next to that, what is the mechanism of this gastric electrical stimulation before winding up? This is nothing but your gastric pacing. Do you think it's gastric pacing means? It's not that. It's only by GES. What is that gastric pacing and gastric electric stimulation? Gastric pacing will always be using a low frequency, high frequency, low energy potential. But in gastric electric stimulation, what we are going to use, it's going to deliver a high frequency and lower energy potential, which is going to get delivered. And over a period of time, we need to give for in order to augment this gastric electric stimulation over the antropyloric region, which is going to just place the electrode around 4 to 5 centimeters above the pyloric orifice, where you're going to do the stimulation mechanism. But that shows if you're going to do this process, that shows evidence of some local infection, your lead migration can be there, and no strong consensus statement have been made about this gastric stimulation therapy. Next to that, your various surgical modalities like your gastrostomy, your jejunostomy, your pyloroplasty, gastrectomy can be tried in your idiopathic gastroparesis or post-surgical gastroparesis who doesn't show any improvement symptomatically, who have significant weight loss, refractory gastroparesis. All those pointers, we can consider the surgical modality as one of the final line of management in the process of gastroparesis. And this is what the final slide, what I would like to show with you all. So they might not be having a strong response. You need to categorize mild, moderate, and severe gastroparesis. Diet establishment, clinical diagnosis, all those pointers to be taken into account. The drug therapy, if not responding, followed by you need to go for a endoscopic modality or Botox, or sometimes you need to go for a surgical correction. This is what the baseline approach, as I discussed, you need to go for a diet, nutrition, pharmacology, and non-pharmacological interventions. And so many herbal supports nowadays being tried, like your ginger, your ginseng analog, so many herbal supports being tried. It's not my area for us to discuss, but you should remember herbal supplements is given in a separate paper now for management of gastroparesis. Once the patient is going to be refractory, you need to go for your manometry or endoflipping. You need to see your antral pressure and all those things. Either you need to go for identify whether the patient is going to have a pylorus spasm is there or not. If it is an isolated pyloric spasm with evidence of antral hypomotility, we can go for intensive medical management. But once a pyloric spasm it is not going to respond, you can go for Botox injection. Even with that, if it is not going to respond, then you can go for GPIM or laparoscopic pyloroplasty interventions. So complementary medications like acupuncture can aid in your increase in your gastric accommodation. All those things can be tried. And what are the questions is still unanswerable, because how far the investigation is going to get successful, whether as per ECG, are you doing this electrogastrogram frequently or not? And next to that, whether the female patient, dysautonomy or vagal denervation, are you analyzing properly? And autoantibodies, whether we are measuring properly. And what is the relationship between your weight and gastroparesis is still a questionable issue, not much of documentation in that. And the gender imbalance, how to explain, rather than your neuronal synthesis and your progesterone analogs, how to explain the concepts. And these are all still how far the GPIM be successful, and vagal modification, vagal stimulation, is it going to be helpful in the management of gastroparesis? These are all the questions still unanswered in the armamentarium of management of gastroparesis. The future direction is mainly we need to go for elastography on deep tissue biopsies and your flip methodology. But I think we need to maintain your tissue banks and close collaboration with your basic science and immunological knowledge. What is going to happen, followed by if you want to manage a patient with diabetic gastroparesis successfully, and clinical assessment, neurological parameters to be ruled out, precipitating factors to be eliminated, and diabetes, thyroid, all those events to be controlled well, optimization of your insulin, nutritional management, pharmacological assessment, and side effects of your pharmacological drugs, your endoscopic modality to whom you're going to recommend, followed by your surgical intervention. Is it necessary to the patient? All these things to be analyzed properly if you want to manage a patient with gastroparesis. With this, I would like to rest my presentation, and I'm happy to take up your questions if anything is there to take on. Thanking you all for patient listening.
Dr. Arun, thank you very much. Thank you very much. It was very exhaustive. You have had covered almost everything on gastroparesis, right from definition. You had classified the gastroparesis. You had looked into the pathogenesis. You had clearly shown what gastroparesis is all about, and in various investigations which is needed, clinical features. You have discussed in length about the treatment modalities and the various drugs used, endoscopic, non-endoscopic treatments, surgical treatments, and what are the questions that might that are left unanswered. You have turned around to give a wonderful overview on gastroparesis. I did enjoy your talk, but I'm sure there will be some pressing questions from the audience. We'll just see if we have any questions now. I'm just going to go and switch on to see if we have questions. Yeah. Somebody wants to ask Dr. Vipul Chabra, is there a role of probiotics in gastroparesis?
There shows some paper, there is some evidence of role of probiotics in gastroparesis, but in various recent trials, what I mentioned in ACG, it shows no much of significant benefits. But when you're taking a separate paper for discussion for lactobacillus rhamnosus GG, that shows some evidence because it may improve your gastric emptying. Also, there shows some papers for your lactobacillus reuteri, also shows some beneficial effects for your gastric emptying, which is going to get involved based upon how does it going to alter your gut response, how does it going to involve your defensive process, all these mechanics to be involved in your gastric emptying. But the significant potential role in managing a patient with gastroparesis with probiotics has not been fully documented at now, sir, as of now.
Okay. Wonderful. There is another question from Dr. V. Balasubramanian, drugs producing gastroparesis.
The huge list of drugs that are what have been shown to you, sir, but the common drugs what we are going to look in is anticholinergics is main common molecule, anti-Parkinson is a molecule, and so many other neurological molecules will be predisposing. For example, your beta agonists, your calcium blockers, so huge list of drugs are there, but how far you are going to remember those things are not a different pattern. But when you're going to manage, use only common molecules. think whether the patient is having evidence of gastroparesis worsening or not, and see whether the molecular interaction is going to happen based upon the drug what you're going to use, followed by you design your management pattern.
My question to you is that when you see a patient, when we discuss about gastroparesis, we do come across, when we do our endoscopy, after a prolonged period, we just tell the patient that you fast for X number of hours, at least minimum 4 to 6 hours before they turn up for endoscopy. At that time, the only way I suspect gastroparesis is that when a patient comes to me with prolonged fasting, has an endoscopy done, and see that he has got still food residue in his stomach. That's when I start suspecting gastroparesis. In your practice, as you go by your patients in whom you suspect gastroparesis, are there any criteria? Do you do gastric emptying studies on a regular basis, or you clinically suspect gastroparesis and start them on treatment? And how is your practice?
In our experience, sir, to investigate that too in Chennai or most of the centers in India, to identify a patient with gastroparesis, in order to do a gastric scintigraphy and all those modality of assessment is still a difficult task for us to manage, sir. And next to that, when we are going to see most of the patient within a period of 4 to 6 hours, even the patient, if the patient is going to be hospital admitted patient, there will not be any much of activities at that point of time. There shows evidence of gastric emptying, and also in the background of obesity, in the background of diabetes, in the patient within the background of any other coexisting gastric pathology. So this kind of patient may harbor delayed gastric emptying. So for this kind of patients, we need to go only with what as you have been discussed with your clinical presentation, the clinical knowledge and clinical examination only. We need to manage a patient with gastroparesis, and we need to really see, sir, whether the patient is responding to the management or not, rather than going only for the investigation modality. But once you're going to decide for this kind of patient who's going to land up with investigation modality, who shows evidence of refractory, even with 2 molecules, if you're going to try, that shows no evidence of any clinical response, the worsening of event, that shows evidence of weight loss, as what I mean discussed with the basic severity, which shows evidence of gastric failure and other pathology to grade as grade 2 to grade 3 gastroparesis, then there is possibility, then there is pointer for us to take on with the scintigraphy and other modalities of investigation, rather than jumping for all the patients to do this investigation, sir.
So do you mean to say that you should? So when do you suspect gastroparesis? Do you suspect somebody has gastroparesis based on?
So your voice is breaking, sir.
You go for treatment, or the only question is that do you investigate or you don't investigate? I do accept the fact that investigating and diagnosing gastroparesis is extremely difficult. See, in my 15 years in Apollo hospitals, I have done gastric emptying studies at least 10, 15 times only. Most of the times, gastroparesis had always been a clinical diagnosis. It has not been proven, number one.
Yes.
I agree with you that doing scintigraphic studies is extremely difficult. There you have a test meal where a radioactive material is mixed with the test meal, and unfortunately, the mixing, in the process of mixing, the test meal and the scintigraphic material can get separated, and you can get absolutely wrong values. Number 3, it is very, very, very important that people should understand that there are 2 types of gastric emptying studies, where you look at a 2-hour gastric emptying and a 4-hour gastric emptying. It is important to note that between 2-hour and a 4-hour gastric emptying, 4-hour is more important than 2-hour. 2-hour, less than 60% emptying, then you know that this is delayed gastric emptying. Or 4-hour shows less than 10% still, more than 10% still in the stomach, you know that it is delayed gastroparesis. But when they compared the 2-hour and 4-hour, they found out that you missed by about 20-30% of the patients who had true gastroparesis. So it is important, as you stressed, a 4-hour gastric emptying study is very important. It is scintigraphic study. All scintigraphic studies are all tagged to solid bodies. So you can get only solid emptying. You don't have a separate liquid emptying, which is again important. So considering that there are chances that you may not be able to get a true value of gastric emptying, I agree with you, you should go only by Clinical means. What are your armamentarium? What are the drugs you currently use in treating gastroparesis?
So right now we are using, but my experience with metoclopramide right now, basically I am not using much for any patient who is having evidence of gastroparesis. But initial studies, what we mentioned, metoclopramide to start with slightly in the range of around 10 milligrams, followed by to go with 20 milligrams. But frequently, since the patient side effects is being more, it's not being much of my consideration. I can go for other if you're going to have a Scintigraphy, it's one more strong point of what we can consider for the management of gastroparesis. Now it's strongly been identified. And next to that, liver sulfide also, that shows evidence of your blood-brain barrier crossing and other various evidence of other neurological parameters also being reported. So liver sulfide is also a questionable issue when you're going to manage a patient with gastroparesis. But Scintigraphy, the safety profile is slightly in the higher side when compared to other molecules. So I'll be going for the slightly high potent prokinetic molecules if you're going to manage a patient with gastroparesis.
Let me check if there are any more questions from the participants. I haven't received any more questions. Just to complete the meeting, I just want to ask you one more question. What's your experience about using acosamide?
So using acosamide is definitely very easier, but the experience for me to use acosamide rather than in gastroparesis in functional dyspepsia is slightly easier for me to target. And when I'm going for acosamide, initially what we are used to do is 100 milligram TDs. Now what we are going was a OD dose regimen, like 300 milligrams is being still usage. And acosamide, we need to target the postprandial bloatedness is the most important event, and early sedative definitely is going to have a significant response when you're going to use acosamide as a reasonable molecule. But gastroparesis, to manage, if you're so strongly suspecting only gastroparesis, rather than going for acosamide alone, it's better to go for a strong potent prokinetic. That's my approach, sir.
What would be your take-home messages for the talk today on gastroparesis? Do you say gastroparesis is very, very important, and treating gastroparesis important? What do you think should we do about gastroparesis? Are we underdiagnosing gastroparesis? Are we treating gastroparesis adequately? And by the way, as you said that you classified gastroparesis, 30% may be idiopathic, 40% can be diabetic, and another 20 may be due to other causes, obstructive, and so forth, so on and so forth. But what do you think are going to be the take-home messages from the talk today?
So the take-home message from the talk, what we would like to conclude, is the identification of a patient with gastroparesis is definitely a difficult task, because as a gastroenterologist, we need to target whether the patient is having endoscopic approach, and based upon the clinical assessment and all those pointers to be taken, whether the patient is going to have evidence of gastroparesis is there or not. Because the various investigations that what I've been discussed with you all is definitely a questionable issue when we are going to use for common people in India. And how far it is going to be successful, it's definitely the next thing. And how the molecular target we are going to do. And next to that, once the patient is showing evidence of refractory, whether we are giving a maximum dose of two molecules where they have been tried, that's how we need to use. We need to titrate our dose. We need to analyze whether the gastroparesis is still active or not. Followed by, once the symptoms is not getting improved, at that point of juncture only we need to report the patient for other higher investigation modality. So in India, always we should remember that the diabetic capital, and nowadays even in younger age group, the obesity is going to have a predisposing event. And next to that, your thyroid related problem, your various autoimmune pathologies, which is being the diagnostic method is still in the tip of iceberg. We couldn't be able to identify most of the events nowadays. That's why identification of the patient with gastroparesis itself is a difficult task even for the senior consultant gastroenterologist. But once we are going to label them as evidence of gastroparesis, to managing a patient, serial follow-up, at least for a period of 12 weeks of therapy, is the most important thing before we are going to switch on to other molecular regimens, before we are going to clinically label this shows evidence of refractory. All those pointers we need to analyze properly, sir, to manage a patient with gastroparesis.
just as a concluding remark, I just want to say that with South India being the diabetic capital, we are likely to see a lot of cases. We are seeing a lot of cases of diabetic gastroparesis. We are missing a lot of cases of diabetic gastroparesis. It is absolutely important because if a diabetic patient has got gastroparesis, they are more vulnerable to poor diabetic control, more vulnerable to repeated episodes of hypoglycemia due to incoordination between the gastric emptying and the medical intake. It is absolutely important. You have to improve the diabetic control in diabetic gastroparesis as well. Make sure that they have a proper gastric emptying to improve this is like a chicken and egg situation where one leads to the other, it goes on. You have to correct either of them, particularly in gastroparesis, for a good diabetic control and for them not to develop any side effects. So with us being a diabetic capital, we are seeing a lot of cases with diabetic gastroparesis. Unfortunately, I agree with you that we are picking up less, but you should have a low threshold to pick up these cases. Maybe once you suspect clinically or during when you do endoscopy or based on their symptomatology, rather than going for the tests, you can definitely start them on the most appropriate drugs. And I do agree with you, there are quite a big armamentarium of treatment, with the latest entry being the GPOM, as you rightly pointed out. There are also palliative thing for severe gastroparetics. Gastrectomy is the worst thing that you should do for gastroparesis, but unfortunately, in severe cases where there's nothing to be done, people have to have a venting gastrostomy, may subject them to gastrectomy also if the gastric emptying is very poor. We have got a long list of drugs for gastroparesis. Unfortunately, we don't have IV erythromycin, but we tend to use oral erythromycin, particularly in my lung transplant patients who end up in gastroparesis. We do use a lot of oral erythromycin with a little bit of not as much as the IV erythromycin. With this concluding remarks, and thanks, Dr. Arun, for a wonderful overview into the subject. It's quite difficult. We haven't got any more questions on the from the viewers, so I think we should. We are already running late, and we should end the session. And I will hand over the mic
Thank you.
Krishna Shetty and Inkersal. Thank you very much, sir.
Just a minute.
Thank you very much.
First of all, thank you very much. Good evening to all once again from Krishna Shetty from Torrent Pharma. I take this opportunity to thank Dr. N. Arun and Dr. M. Hariharan for this wonderful knowledge feast. It was indeed a splendid session. We thank you both again for all the effort and energy that you have put in for this event. And also we are grateful that you could spare time out of your busy schedule for this event. So on behalf of Torrent Pharma, I would also like to thank all the audience for making the event a success, and we hope your support will remain with Torrent in the coming times too. Thank you one and all. Have a wonderful evening, sir. So really thank you very much for all the time that you spared. It was really a nice session, and we'll also just come back to you on this feedback also from the team. Thank you, sir. Thank you very much.